Good evening, and thanks to everyone for joining us today. On behalf of NAARI Division of Jagsonpal, we welcome you to this webinar today, organized by Haryana chapter of ISAR. New information for you, this is our My Sakhi CSR initiative, which has been in existence since April this year. Apart from this, I take you through our products which are associated with PCOS and associated infertility, Cystelia-M, that is myoinositol and decairoinositol, 40:1 ratio. For androgenic side effects, PCOS, acne, and hirsutism, we have Cystelia-35, cyproterone acetate, and ethinyl estradiol, the most dependable OC pill. And for male infertility, we have LycoRed-M. We welcome you all to this webinar, for which Dr. Jyoti Malik, the chairperson, we invite her to initiate the program. Ma'am, over to you.
Thank you so much. Thank you, Dr. Deepika, and thank you, Jagsonpal. And on behalf of ISAR Haryana, with our mission motto of Prayas Evam Vistar, I welcome you all for this Inspire and Ignite series number 8. And with the blessings of our National ISAR President, Dr. Ameet Patki sir, and Secretary General, Dr. Asha Baxi ma'am, I am thankful to the complete National ISAR team for giving us the opportunity to be there, and they are always there for our support. And we just recently witnessed a beautiful National ISAR Embryology Conference at Chandigarh, which was conducted along with ISAR chapter Punjab and Haryana. So our national leaders are absolutely great leaders, and they give us lots of opportunity to move ahead and to learn together and to share and do better in our practice of infertility. And we constantly, also with the support of ISAR team, we also keep doing the once a month journal club. So thank you very much, Dr. Patki sir and Dr. Asha ma'am. And then we have our ISAR Haryana team, Secretary Dr. Meenu, the Clinical Secretary Dr. Manju Dagar, and the Treasurer Dr. Lakshmi, who have been a great support, doing a lot of things, lot of activities, helping around for the ISAR Haryana chapter to grow. And then we, on this, now I would also invite Dr. Lakshmi to please carry on this part of the program and invite and let us know about the conveners for today's conference.
Thank you, Dr. Jyoti. Let's start with the today's web series. Today's web series is on PCOD, and we have different committees in our Haryana chapter of ISAR, and in the PCO committee, which also includes the POR and the Reproductive Endocrinology Committee. The chairpersons for the committee are Dr. Rakhee Malhotra and Dr. Manju Khurana. And the vice chairpersons are Dr. Meenakshi Mehta and Dr. Pooja Bhayana. Now I would invite Dr. Meenakshi Mehta to introduce the chairperson and speaker for our first talk. Over to you, Dr. Meenakshi.
Thank you, Dr. Lakshmi. I welcome you all for our first session. The topic is long-term consequences of androgen excess. And the chairperson for this session is Dr. Jatinder Chadda ma'am, Dr. Rakhee Malhotra ma'am, Dr. Sangeeta Jain ma'am, and Dr. Renu Chugh ma'am. Now I would like to invite Dr. Rakhee Malhotra ma'am. Please introduce our eminent speaker, Dr. Pratik Tambe.
Lakshmi for giving me the opportunity to chair this session, and thank you dynamic chairperson Dr. Jyoti for beauty with brain, I must say, chairperson. So it's a great honor to introduce Dr. Pratik Tambe, who is Ashirwad IVF Mumbai, and she is from France. He's trained in assisted reproductive in Belgium and trained in clinical embryology and ICSI at London and Singapore. She has been associated with so many posts. There's a list to go on, governing council member, ICOG, governing council member, IC of reproductive medicine. She was the past chairperson of FOXI Advertising Committee, past chairperson of Emergency Enterprise Committee. We are blessed to have you, sir, here.
Thank you very much for the kind invitation and the
And to hear
introduction.
such an important from you, the word of wisdom.
And thank you, Dr. Pratik, for accepting our invitation at one call. And once you listen to Dr. Pratik, I think every time he gives you such clear messages, and he's a wonderful orator. Thank you, Dr. Pratik, for joining us. Thank you. Over to you.
Thank you very much, Dr. Jyoti Malik and Dr. Minu Handa, Chairperson and Secretary of the Haryana chapter. We recently had this wonderful ISAR Embryology Conference, which was held in Chandigarh, and the Haryana, Punjab, and Chandigarh chapters all came together. Amazing, amazing occasion. And I had the good fortune to interact with many of you there in person. Today's talk is going to be a short talk, hopefully 20-25 minutes. I won't bore you beyond that. And this is on the long-term consequences of androgen excess. This is an important topic because we often don't talk about this, we don't discuss about it. And there are many internal medicine and endocrinology concepts which we as general OBGYNs may not be so well aware regarding these concepts. So let's get started. Both the optimist and the pessimist contribute to society. The optimist invents the aeroplane and the pessimist invents the parachute. Whenever I speak about something, I like to start by asking whether the subject is clinically relevant. Obviously, PCOS is something which is increasing by leaps and bounds throughout the entire world. This is one beautiful landmark study which looked at the global disease burden in 194 countries. It was published in 2021, just around the time of the pandemic. So many of us have missed this paper. And they found that over 10 years, there was an increase of nearly 4.5% from 2007 to 2017. And the age standardized incidence of PCOS amongst women in reproductive age also increased significantly. India is also one of the major contributors to the global disease burden and the increase in PCOS incidence. Now, as far as the long-term consequences of this disease were concerned, they were known since at least 2 decades. And in November 2014, the RCOG came out with a Green Top Guideline number 33. And this, of course, needs to be updated. Hopefully, over the next couple of years, it will be updated. There are also plenty of frequently asked question leaflets for patients, and these can, of course, be translated. And if you have patients in your own setup who are inquisitive about these issues, then this is a very nice template for you to start from so that you can translate it into the patient's own non-scientific language and you can convey this information. We had the ASHRAE guideline address this in 2018, and the updated guideline published in August of 2023 also has very important sections in the guideline regarding this issue. So let's go back a little while, say about a couple of decades back, and there was a dawning of realization that there are long-term health consequences of androgen excess, which is part and parcel of PCOS. And this is a human reproduction update from way back in 2002. And this concluded by saying that women with PCOS have cluster risk factors for diabetes, cardiovascular disease, endometrial cancer, and it issued a warning regarding the major public health implications of PCOS. When we look at the pathophysiological basis of the disease, we realize when we look at the 2-cell-2 gonadotropin theory that hyperandrogenemia, hyperandrogenism, and androgen excess are the basic pillars on which the entire disease process is founded. Therefore, whenever you have an excess of androgens, you will realize that there are several metabolic derangements which go hand in hand with this condition. This includes altered insulin sensitivity, abnormalities of glucose metabolism, and excess androgen secretion. In fact, what we know as OBGYNs may be only the tip of the iceberg, because there are a lot of metabolic consequences of this androgen excess, which are there beneath the surface, and which you and I as ordinary OBGYNs are not trained to understand. We often don't look into these things, and we are therefore unable to counsel our patients as well regarding the implications of these problems. What happens is over a period of time, having unopposed excess estrogen and androgens leads to increased cardiovascular risk. increased risk of type 2 diabetes, there is high circulating free testosterone, and that leads to the physical manifestation or the phenotypical manifestation, which you and I are very familiar with, but the underlying issues are, of course, equally important. Now, when I talk about the underlying problems which occur, what we are not often aware of is that androgens influence a certain type of molecule or a certain set of molecules which are called as adipokines. Now, I'll be very honest with you, until 10 years ago, I didn't even know that such a term existed. Adipokines was something which was very new to me when I started reading up more and more in depth about PCOS. And these adipokines are like cytokines, and they are actually responsible for the entire disturbed intracellular mechanisms and which cause obesity. All of us know that obese classic PCO is one of the major types and the most common types which we encounter in our country and also in the Western countries. But what we are not often aware is that these adipokines and excess androgen lead to something called as an excess of visceral adipose tissue and truncal obesity. This leads to a male pattern truncal obesity, and this visceral adipose tissue, in fact, functions like an independent endocrine organ. This leads to excessive circulating as well as local cytokines, and that's why I'm very fond of saying that PCOS is a chronic inflammatory disease process. It is not only a disorder of ovarian function, it is not only a disorder of oligo-ovulation and anovulation and just creating ovulation, addressing the infertility issues is not enough. You and I need to have a holistic view, and we need to be able to counsel our patients regarding the disease process. We can only do that, of course, if we ourselves are aware of what actually is happening beneath the surface. So these excessive and circulating local cytokines cause a chronic inflammatory process. There is an abundance of reactive oxygen species. And from your and my experience with ROS and male infertility, we are aware that just as the ROS attacks the sperm at various different levels and causes sperm DNA fragmentation and poor fertilization, capacitation, etc., similarly, this ROS is also going to have a harmful effect on the oocyte quality, and also a host of other cellular mechanisms which we often don't understand. In fact, it has been found that excess of ROS leads to a resistant kind of insulin resistance where patients are not easily responding to the standard methodology of treatment which you and I take recourse to. In fact, it has been found that if you look at all the different markers of insulin resistance, research, especially in Indian patients, has shown that measuring the plasma insulin fasting and postprandial is one of the ways in which we have traditionally looked at insulin resistance. But the most sensitive marker seems to be actually the waist hip ratio and the waist circumference, and that directly correlates with the abdominal adiposity and the visceral adipose tissue, which we've been talking about. And I think this picture illustrates it nicely. If you have excess of androgens, you have a male pattern abdominal adiposity which occurs, and underneath the surface, there are hundreds of different molecules which are elevated. These are tissue markers, and when you look at the entire list, it's too exhaustive for me to actually sit and read out. Many of these have been discovered only in the past 5 to 10 years, and probably over a period of time, when all of this becomes mainstream, we will actually be able to go out and measure levels of these different tissue markers and devise targeted therapies so that we can nip the long-term consequences of androgen excess in the bud. As of now, measuring these is beyond the scope of clinical practice. This is only something which people do in the confines of a research trial, but you will find very familiar molecules which you've heard of, including the interleukins, tissue plasminogen activator inhibitor, antithrombin 3, and so on and so forth, which we often have come across in our younger days when we were reading, or maybe a completely different subject. Coming to South Asian PCOS, what we now know is that the PCOS that we read about from Western guidelines is not exactly the same as the PCOS which you and I encounter in clinical practice. In fact, South Asian PCOS is a very different kind of PCOS. It's a resistant kind of PCOS where women have severe hirsutism. There's a lower SHBG, a higher free androgen index. There is a severe insulin resistance which doesn't easily ameliorate with the standard therapies that we offer our patients. There is a significantly higher prevalence of acanthosis nigricans because of the genetic and different hereditary predisposition of Indian women. And you can have a lower BMI, but unfortunately, there is a greater prevalence of central adiposity and visceral adipose tissue. What happens is Indian women are much more prone to metabolic syndrome, and this metabolic syndrome can happen quite early. What we've always read about, if you remember your Spiro from the 90s and early 2000s, we were always taught that you're going to have metabolic syndrome after 20, 25, 30 years of unopposed estrogen and androgens. That is no longer true. We are now finding that you can have metabolic syndrome which presents very early in life, and sometimes even youngsters and adolescents are being diagnosed with metabolic syndrome. Therefore, these women are unable to keep off weight. They have clomiphene resistance. There's poor endometrial receptivity. All of this translates into a lower fertility. It's not only an issue with ovulation, but there are a lot of other complex factors which are also at play. There is more and more evidence, and after 2002, when the first human reproduction update came out, there were also other papers which came in over the next 10 to 15 years. This is a review analysis in 2009. One more review published in 2015. There's an update published by the Endocrine Society in 2021, and Dr. Ahuja was one of the authors in this paper. And all of these studies said regarding specifically diabetes that 25 to 30% of women who have PCOS are going to have impaired glucose tolerance by the age of 30. 8% of affected women will develop frank diabetes, and the prevalence of type 2 diabetes is 7 times higher as compared to age-matched controls. This is significantly higher in women who are from Asian descent and in North America, and this is also increased in non-obese women. It is not only the obese classic PCO women who are more prone to DM, it is also the lean PCO women. As far as cardiovascular disease is concerned, this is much more extensively studied, and there are two mechanisms which are responsible for this increased cardiovascular disease risk. There's a direct atherogenic action because of the change in the lipid profile, and there's also going to be an adverse effect of the lipoprotein profile, which we will just talk about in a slide or two. It's been found that HDL, which is the protective type of cholesterol, is suppressed in these women. Usually, this would happen much more after menopause. These changes in the lipid profile would happen in a woman post-menopausal. They would not happen while she's still in the reproductive age. But in PCOS women, it seems to happen much before menopause as well. The higher concentrations of serum triglycerides are found, and total high-density lipoproteins are also found. Tissue plasminogen activator we've already talked about earlier, and impaired fibrinolysis as well we covered. So this in a nutshell is all the changes which happen. This altered lipid profile is something which you and I don't commonly test for. It's very rare for us to actually ask for a lipid profile of a woman who is being diagnosed with PCOS. And that is recommended as one of the screening tests when you are annually or at least once in 2 years looking at these women. We'll come to the screening protocols towards the end of this talk. Let's focus now a little bit on hypertension. What has been found is that there is a direct relationship between plasma levels of insulin and blood pressure. And we know that women who have PCOS have high levels of plasma insulin. In fact, the disease is characterized by hyperinsulinemia, which directly correlates to an increase in blood pressure as well. It's been found that there is a hypertrophy of the muscle wall, especially in the capacitance circulation, and that leads to interference in vasodilatation. As we know that these changes are also seen in women who get pregnant, and that is also one of the prime reasons why preeclampsia in pregnant women is 4 times higher when they have PCOS as compared to non-PCOS women. One of the primary reasons why eclampsia is more common in PCOS women is because of these changes in the vascular compartment, which we often don't consider, which we often not aware. Interestingly, it's been found that there can also be heart failure. And most of us who practice medicine are aware that you can have heart failure when there is an overload of the heart. For example, if there is greater amount of vascular compartment expansion, but significantly in women with PCOS who have metabolic syndrome, who get heart failure with a normal ejection fraction. And this is something which is interesting. When I first read it up, it was found that women who have PCOS are more prone for changes in the vascular compartment without having any other pre-existing high risk factor. Therefore, you need to investigate these women early. You need to have good counseling and obviously need to have a multidisciplinary approach. When we talk about CA endometrium, we are much more on stronger ground because this is basically our OBGYN's area of expertise. The obvious risk factors for developing CA endometrium are all present in abundance in PCOS women. You have obesity, you're going to have long-term unopposed estrogen, 15, 20, 25 years. Many of these women will have pregnancy late. They may also be nulliparous, they may be infertile, and they have a background of hypertension and diabetes, all of which contribute to a 3 times higher risk compared to a general population. The absolute numbers are not high. If you look into the statistics, it's nowhere going to be as close to, say, CA breast or CA cervix, but the incidence is definitely on the higher side, and therefore surveillance and screening is recommended. Let's talk a little bit about metabolic syndrome now. Metabolic syndrome, if you look at the various different textbooks, they will all tell you that this is something which happens because of a constellation of underlying metabolic issues, which are more common in women who have PCOS, significantly higher risk in the hyperandrogenic phenotype, which is 75 to 80% of the PCOS that you and I encounter in the Indian subcontinent. And it's been found that even in adolescents, the risk is at least twice as high as compared to girls who do not have PCOS. So what is this metabolic syndrome very specifically? I found this beautiful paper which actually looks at the management guidelines and it's been published in August of 2022. I'll share the link with you in case you're interested. All of these references are freely available on the internet. They're not hidden behind a paywall. If you want any of them, please feel free to write to me. I will share them with you. So the basic pillars of metabolic syndrome are, the central pillar is obviously obesity, and surrounding pillars are prediabetes or frank diabetes. You can have a high normal blood pressure or frank hypertension, and you have atherogenic dyslipidemia, which is the altered lipid profile, which you were discussing just 5 minutes ago. The diagnostic criteria are very simple. Either you have an abdominal obesity, which is more than 88 centimeters in women, or you have a BMI which is more than 30, and additional diagnostic criteria are the supporting criteria for diabetes, altered lipid profile, and your hypertension. If you look at those 4 pillars, you look at the criteria for each of those, put them together, and if you have them present, then basically your patient has metabolic syndrome. The National Institute of Health came out with these criteria, and they are well known. And in case you want to implement them in your clinical practice, I think very simple and straightforward. Waist circumference of more than 35 inches, high triglycerides more than 150, reduced HDL, that's the protective type of cholesterol, less than 50, hypertension 140 by 90 or more, and a fasting plasma glucose of more than 100. When you look at all these criteria, you'll realize that the triglycerides and the lipid profile typically are not one which you and I would commonly look at. And if you were to include those and you look at all these parameters in your PCOS women, you'll be surprised that a large population of them will be diagnosed as having altered lipid profile, borderline hypertension, borderline diabetes, or gestational diabetes. And the waist circumference obviously is going to be more than 35 inches, which means they are either in the incipient stage or the obvious stage, the front stage of metabolic syndrome. And that is why you need to pick this up early. You need to put in place preventative measures if they are not already diagnosed as frank metabolic syndrome, or in case they are diagnosed, then you obviously need to refer to somebody who has much more expertise than you and I do and make sure that it gets addressed in a timely fashion. So to summarize, the consequences of your abdominal adiposity and your excess androgens include impaired kidney function, liver disease. You're going to have heart failure with a normal ejection fraction, which again was very much news to me when I first came out, read about this concept 5 years back. Obstructive sleep apnea is well known to all of us. You're going to see hyperuricemia and chronic inflammation by default in all of these women. And the next step is the obvious steps which we talk about, that's hypertension, frank diabetes, and altered lipid profile. This is what you can measure. This is very easily measurable. And even in a small practice, if you have the facilities to do so, you will be able to pick up these women. We come to the all important topic of now how do we counsel these women? The RCOG has come up with very beautiful patient information leaflets, which I referred to at the beginning of this talk. It's very easy to take these up, translate them into the local language, and you can give these to your patients. You can put them up in your own hospital website if you want, and make it easily accessible for your patients. Most women, when they first hear about this, they want to know how can they protect themselves because they're very scared of cancer, and they may not be so scared of metabolic syndrome, but diabetes, hypertension, the attendant complications which happen as a result of these diseases are very much scary, and they have had at least some family member who suffered these, so they know what that entails. So the advice that you can offer as a doctor is diet, nutrition, cut down the amount of sugar, caffeine, salt, recreational drugs, alcohol, healthy lifestyle, which we always advise for our PCOS patients, and the benefits of weight loss cannot be underestimated. It doesn't matter at what age you start. You may start at the age of 40, you may start at the age of 45, but the benefits are significantly there no matter how late you start. Regular health checkups for diabetes once a year over the age of 40. If BMI of more than 30 or family history, then you can offer it before 40. This is from the RCOG guideline, by the way. And you are aware of all the others. The recommended protocols for clinical practice as per the SHRI guideline is, I think this is the most important slide in the entire presentation. So if you want, you can take a screenshot of this. SHRI, ASRM, and Androgen Access Society recommends screening every 1 to 3 years, 75 gram OGTT, which all of us do during pregnancy, but we forget about it once the patient has had a childbirth and she's lost to follow up, especially if women have the obese classic PCO phenotype, if they have BMI more than 30, acanthosis nigricans, family history, past history, lean PCOS who are more than 40 years of age. And if you want to add the very strict criteria of the European Society of Endocrinology, they recommend screening all adolescents also with PCOS, and they strongly advise against HbA1c. 75 gram OGTT is the test of choice. As far as cardiovascular disease is concerned, the American Heart Association recommends that you do a detailed history, assess with blood pressure, complete lipid profile, your waist circumference, family history, etc. For endometrial CA, unfortunately, we don't have standardized protocols, but all of you are experts and you know that a good transvaginal scan and early referral is important if the patient has abnormal bleeding patterns. I found this beautiful slide from Dr. Gurusha and the PCOS Society of India, which gives you in a very nice step ladder fashion what should be your advice to patients and what you should do in your own clinical practice. Measure the BMI and waist circumference at every visit. Classify into high risk or low risk. Look for the blood pressure, complete lipid profile, LFT, RFT, waist circumference, BMI, glucose profile, smoking history, family history, etc. If high risk for CVD, then refer to a cardiologist or endocrinologist. Always assess for depression, anxiety, and quality of life. If you find that they have mental health issues, then refer to a psychiatrist. Ultrasound, something which we all take for granted, but please make sure that you do it properly and refer to a radiologist if you're not confident of doing your own scans. Take a second opinion. If there is abnormal bleeding pattern, you're going to require an endometrial biopsy. Lifestyle changes, no matter how late they are instituted, are going to be beneficial. And if you find that the patient is somebody who is a high risk for metabolic syndrome, insulin sensitizers are supposed to help. And if they have hypertension and diabetes, obviously the internal medicine consultant is going to be able to advise them. Just a few slides about metformin, which all of us are aware. Can we control androgen excess? I wish we could. Unfortunately, we don't understand the disease process completely. We need to break the vicious cycle of hyperinsulinemia and hyperandrogenemia at some point of time, because that is what we can see. What we do not see is all the different cytokines and adipokines which are working silently behind the scenes. There is surgery which is available for morbid obesity, and GLP-1 agonists are now available in our country. We have the ISAR guideline for obesity, which has been published just this month. We will share it with all of you when it comes out. We had the Indian National Guidelines on acanthosis nigricans also. This is the group led by Dr. Gurusha. I was fortunate to be part of it. This has also been published last year. And this is the metabolic syndrome treatment algorithm, which is overkill for us because we are not the people who treat it. I would say that if you're able to diagnose it and you're able to refer to the appropriate clinician, that would be more than enough. So to conclude, ladies and gentlemen, PCOS is the hidden pandemic. It confers a higher risk for all patients and all kinds of metabolic issues. It's highest in the obese classic PCO, which is 70-80% of the women that we see in our clinical practice. But that doesn't mean it cannot happen in the other phenotypes. Clinician and patient education is key. There are very good FAQs that are available online. You can use these, modify these. Do not think that if you've got the woman pregnant, your job is done. PCOS is a lifelong condition, and these women will need care in an appropriate fashion even after they have delivered and gone home. Thank you very much for a patient hearing. I'm happy to take questions if there are any.
Thank you, sir. It was a nice, very informative, and very like Dr. Jyoti said, you always pinpoint each and every point very nicely, and it was very eye-opening and very informative lecture. And we thank you so much.
Thank you for having me here.
Thank you, sir. It was really a very wonderful presentation, especially the risk of the cardiovascular diseases, the hypertension, diabetes, and the different guidelines that we've shared, which will really help us in our day-to-day practice and will help us in counseling the patient in a better way. Thank you so much for being here. So let's take our discussion to the next talk. I would request you to introduce our chairpersons for the next talk. Thank you.
A very good afternoon to all. So we are heading towards the next session, which is on management of resistant PCOS. The chairpersons for the talk are Dr. Savita Singhal, Dr. Anju Ahuja, senior gynecologists, and both are at Rohtak. Dr. Neelam Kant, a senior gynecologist at Bhiwani. Dr. Aradhana Kalra, ma'am. The speaker for today for this session is Dr. Shalini. And I feel privileged to introduce Dr. Shalini because I had been her student in the past and she had also been my co-guide in my thesis. Ma'am is a professor at PG IMER Chandigarh and she is very active in academics. She is a member of NMC with special interest in PCOS and endometriosis. She has a vast experience in laparoscopic surgeries for fertility enhancement and endometriosis, and she has a large number of publications, almost up to 100 publications to her credit. And she has written many chapters in books for infertility and obstetrics. So, ma'am, over to you.
Thank you, Pooja. Thank you for having me in Haryana. From the journey I started with Pooja as a very junior consultant till now, I have led a passionate life treating PCOS And I'm really privileged myself to be here and talk about this. I mean, a topic which is so close to my heart. And also, I've seen Pooja grow all these years, and I feel proud for that. So,
Thank you so much.
So, over to my topic. I'll share my slide. Yeah, can you see?
Yes, ma'am, it's visible.
Yeah, yeah. So I've been given a topic to speak on dealing with a non-responsive ovary. So, I mean, I feel very sad these days when I get a patient who has undergone an IVF outside and she has PCOS with donor two sides. We need to aware ourselves how we can treat this enigma. So one of the biggest achievement in the progress of reproductive endocrinology is the ability to induce ovulation in an anovulatory infertile PCO ovary, and therefore leading to fulfillment of this women's desire to procreate. It was in 1956. Just think, before 1956, these women were considered androgenized women. I mean, they were not able to conceive just after 1956 with a simple tablet of clomiphene citrate. Fertilizations and pregnancies began. In 1980, another step came when the letrozole was discovered, and then began the new era of competition between the two drugs. I mean, maybe the king was lost, and letrozole became the new king. We have advantages of using gonadotropins, and gonadotropins are both advantages, and there are a lot of disadvantages when we jump to gonadotropins. So how do we define a resistant PCOS? The ovary which fails to respond to ovulation inducing agents are considered resistant to that ovulating agent. Most studies involved clomiphene citrate, and therefore a woman not responding to clomiphene citrate was considered clomiphene citrate resistant. And then came the letrozole resistant women. And now we are seeing a lot of women who have gonadotropin resistance also. So the clomiphene failure is something where the women fails to conceive despite ovulating with clomiphene, or letrozole failure, or gonadotropin failure. These all three can happen in women who have PCOS because of the metabolic derangements. Now, how do we describe resistance? A woman is started with clomiphene citrate, 50 milligrams. She does not ovulate. Next cycle, we give her 100 milligrams. She does not ovulate. Previously, we were giving 150 milligrams. Now we do not give, apart from the women who have thick endometrium or well-formed endometriums. There we do give sometimes 150 milligrams. In a woman who fails to ovulate with clomiphene citrate, we go to letrozole. And nowadays, we are preferring letrozole as most of the studies are saying. However, I am still not convinced, because I've been using, I mean, tons and tons of clomiphene citrate, and we have had so many pregnancies. So, I mean, because the literature is saying, and I still feel the studies are not that, good quality studies which have compared end to end, and the number of patients are satisfactory, where the conception and the pregnancy rates have been compared, even though a lot of guidelines are saying, because I have seen my era of clomiphene citrate. If she fails to ovulate, or we do not see a dominant follicle, then we move on to higher dose, which is in letrozole, it is 5 milligram. And then if she does not ovulate with 5 milligram, then we go to 7.5 milligrams, and we look at the follicle. Now, when the women fails to ovulate with both the drugs, it is the time to introcept. What has happened? Is her TSH normal? Is she having a normal prolactin? What is wrong? Or there is something else which is not letting her ovulate? And this was the study which we did, and it was published. And this is one of the 3 studies where the stair-step protocol has been used. So if she does not ovulate with letrozole 2.5 milligram. Just when you are doing the mid-cycle scan, you move on to the higher dose. Then if she does not ovulate with 5 milligrams, you move on to 7.5 milligrams. So this we did with clomiphene citrate. Now we have also done with letrozole. So I mean, this saves a lot of time, and you are able, basically you have to titrate the dose at which the patient starts ovulating. Now, if the patient is not ovulating, so the woman who fails to respond, now what next to be done? So the non-responsive ovary, maybe, the pathophysiology is playing its role. So it is the obesity. Is the dose insufficient? Or maybe there are the metabolic problems which are not letting her ovulate. So what are the metabolic problems? We have to see. Now, this is the time when I asked my resident to now do her metabolic workup for whether she has a metabolic syndrome. So what are the components here are hyperinsulinemia, dyslipidemia. Dr. Pratik Tambe has really talked about it. So hyperandrogenemia and high estrogen, and the most problematic is the last point here, which is the high LH levels. So now, when we are evaluating, we look at the blood sugars at this point, because now we are going to add on insulin sensitizing agents. So before you add insulin sensitizing agent, you must look at her baseline sugars, because after that you will never get to know whether she had inherent diabetes or not. So you look at the fasting blood sugar, HbA1c, or get an oral GTT, and also get the fasting insulin levels done to know whether she has insulin resistance. Now look at the dyslipidemia, get the triglyceride levels done, and look at whether she has associated fatty liver, or she has and if she has associated fatty liver, you will find most of the PCOS women, they will have vitamin D deficiency. And you think vitamin D deficiency is a chance, whereas this is related to her fatty liver, which she is having because of the syndrome. Now the gonadotropin levels you get done, and the problem is the LH is almost double the FSH. And the women who have very high LH levels, these are the women who will not ovulate, who will not get a good oocyte. And even if you have a very good fertilize, there will be no implantation. And if implantation occurs, there is going to be a mid-trimester loss. So you have to correct this, and you should know how you have to correct this. Now, high estrogen levels, these are the clinical implications, are the thickened endometrium and endometrial hyperplasia. Now, Dr. Pratik Tambe talked about endometrial carcinoma. There are so many patients who are coming after IVF, they have got the embryo transfer done, and after that, the endometrial biopsy is done, and it shows endometrial carcinoma, or a small polyp is there, where there is atypia in the endometrial hyperplasia, which should not happen in a well-read clinician's clinic. Now, hyperandrogenemia will cause low serum hormone binding globulins, and there is going to be a lot of free testosterone, which will impact your oocyte quality, and there is clinical hirsutism, and no matter what you try, you will not get a good endometrium. And the clinical very simple presentation is that there is a male pattern of balding. Now the AMH levels, when the AMH levels are very high, you look at the big ovaries, and you know you are going to have, now this is a non-responder. The moment you start gonadotropins, she is going to hyper respond, and the LH is very high. You are not able to get a pregnancy in this patient. So this is again a problem group of patient. Now, when I say when you look at the metabolic syndrome in PCOS, we must know what is the metabolic syndrome. There is features of insulin resistance, obesity is there, dyslipidemia, and hyperandrogenemia. 43% of the adult women, therefore, I can say 43% of the PCOS women will have a problem with ovulation induction. So, and 1/3 of the teenage girls who are diagnosed, they are now having metabolic syndrome. Now we have seen that the incidence is actually rising. So these are the different criterias. I would not go into basically, because then it will become more theoretical. But basically, you take a measure tape and go around the waist, and it is more than 88 centimeters. That means that there is metabolic syndrome. There are elevated triglycerides. You have the HDL levels are low, and the blood pressure. You must look in a woman who is not responding. Responder, forget about them. Non-responder is a problem patient. You must concentrate on the evaluation. Then you look at her sugars, whether she has overt diabetes or she has impaired glucose tolerance test. So now insulin resistance? We look at what are the problems with insulin resistance. There is phosphorylation. These things are causing microRNA alterations are there, and there are mitochondrial dysfunctions are there. And these all impair the fertilization and hinder the implantation. Now, the metabolic syndrome in PCOS, if I go further, adipocytes secrete so many, I mean, as Dr. Pratik Tambe said, it is an inflammatory state. So there is an inflammatory state is present. So how to tackle this inflammation before we make her fit to, I mean, ovulation, forget about the ovulation. First, treat her so that if you get a pregnancy, that pregnancy is sustained. So, of course, the lifestyle modifications are there. You have to go and emphasize, but you don't have to stop treating the underlying metabolic syndrome if you want a successful pregnancy and you have to have a good outcome in your IVF center. Now, this is a paper which says the obesity alters ovarian folliculogenesis through the increased IL-10 production. So we all know that obesity may disrupt normal folliculogenesis, and long back in 2006-7, we had one PhD student who had done the biopsy of adipocytes and found dysfunctional insulin growth factor levels in the adipocytes. So coming to hyperandrogenism, we all know that this also again causes the inflammation, and there is decreased implantation in these patients. Now, dyslipidemia, we've already talked about. So there is associated fatty livers and fatty liver, and there can be cardiovascular risk factors in this. So now, insulin resistance, as I talked about, that increases the risk of abortion. There is impaired implantation. There is increased first trimester abortion. And there are so many times when I go in the ward round, I see a mid-trimester loss. I look at her hair and she has facial hair. She has undergone an IVF and she's not able to sustain a pregnancy. It is not even twin, triplet. It is a singleton pregnancy she's not able to sustain because there is cervical incompetence associated with her high LH level and because of the insulin resistance. So the embryonic factors probably do not contribute to the pregnancy loss in PCOS, but it is the hormonal imbalances which impair the metabolic microenvironment critical for oocyte maturation and endometrial receptivity. Now, this is a very recent paper. This is I feel proud to say this has come from India, and this is by Dr. Surveen and her group. The LH-HCG ratio is altered, and high androgens per se do not let a fertilized embryo implant, and this makes challenging to deal with these women with very high levels of HCG. HCG, LH, all is altered, and actually the HCG is rising much beyond because of the high LH, and this is leading to implantation failures. So what is a high LH level doing? The elevated LH level in the follicular stage is associated with a decreased embryo quality, and there is a early recovery, and there is impaired meiosis, and there is sometimes there is premature ovulation, and there is definitely what all I said is implying over here. Now, the next step is how you are going to manage. Now you've reached a point where you know the LH is very high, there is a metabolic syndrome. So what do I do next? Shall I jump to gonadotropins or shall I do ovarian drilling? Ovarian drilling, we know, has lost its, a lot of, there was an uproar of ovarian drilling, and now that era is gone. So what do we do? No, we will not do this, but treat resistance before gonadotropins, and that is insulin sensitizers, metformin and myo-inositol. Now, it is not that you start metformin or myo-inositols and the next day you start preparing her for IVF. Of course, I know there is a risk of patient running away, but if she understands what we are doing, then she is probably likely to come back and understand. And at the same time, you do the lifestyle modification. Now, giving metformin, it will there is a decrease in the insulin resistance, the hyperinsulinemia will fall, the androgen levels will fall, the implantations will improve, the inflammations will decrease, and there will be definite improvement in the oocyte quality. So myoinositol, again, we all know a lot about them, that they have their dietary supplements and they are down regulating the release of free fatty acids from the adipose tissue, and they are helping in some way. So we want something to which is going to help, even if the studies are deficit. These are the patients, we are very desperate. We start them on metformin and myoinositol, and we will let them continue for 6 weeks. And by 6 weeks time, or by a minimum of 4 weeks, the metabolic profile starts improving, and our results of the treatment will start improving. Once we know that the patient, the best example is that the patient starts having normal period. These are the patients who have started responding to therapy. So again, coming to the high LH levels in PCOS. So under the effect of LH, we know that the problem is now, even if I have given all this, I have given metformin, I have given this, still there are patients who are not going to respond. So then I come and review again what options I have. Is there a role of spironolactone? I have tried spironolactone with COCs pills, giving them for 3 months, and again doing some patients. I remember one thin lean PCOS who was a non-responder. She became pregnant, and there were 3 more patients who had responded. There is some role of GnRH analog, which I will discuss. So coming to the protocols we have for this, there is a role of follicular phase GnRH. Of course, we know that we have the 2 protocols, the agonist protocol and the antagonist protocol. The agonist protocol looks very nice because it will put down the LH level, but the problem is that it will lead to hyperstimulation. I don't know, my study has gone haywire, but probably I'll come through that. So there is a role of follicular phase GnRH agonist protocol. So what you do is, on the 2nd or 3rd day of the menstrual cycle, you give her, if she has very high LH levels, you give her GnRH analog, and then after 28 days you get the serum levels done, and then you start her on recombinant FSH. And but the problem is, if she hyperstimulates, again there is a risk of hyperstimulation. Then you have to give her HCG in a titrated dose. I mean, in this particular study they have used low dose HCG for trigger. So the other, I mean, I was talking about the conventional GnRH antagonist versus the GnRH agonist protocol. This was a meta-analysis which did show that GnRH antagonist is a safer protocol than rather using the long GnRH agonist protocol, which is more likely to have more risk of OHSs. Now, the LH suppression following different low dose of GnRH antagonists, they have used genirelix. So this was a study done in 2007, but it has a definite role. They used different doses of antagonist in the follicular phase, and then they did the levels of the LH and FSH and all the hormones. The only thing they found was that the moment you give antagonist, within 12 hours, the LH level will again rise. So you have to give repeated doses, and they did not do the ovulation induction. This was only LH suppression, and they tried ovulation induction after down regulating her. So this is a very nice protocol I found, LH-based flexible GnRH antagonist protocol. The timing and dosage of antagonist administration was based on the serum LH on day 5 of the ovarian stimulation. So they have used, if the LH level was less, they have used 0.125 milligram of cetrorelix in the follicular phase. Then if the LH was a little higher, they have used 0.5 milligram cetrorelix. And if it was even higher than more than 15, then they have used 0.5 milligram of cetrorelix. This was continued throughout the follicular phase, and then the need for antagonist co-treatment is dependent on the LH concentration. If it is more than 4 international units, after 2 or more follicles were achieved, then they have used triptorelin and done the pickup. So this was a very, very interesting paper I came across, because now and then we come across a patient who does not respond to gonadotropins also. Now, this was another novel GnRH antagonist protocol based on the LH level versus traditional flexible. Here they have started, if the LH level was higher, they started the antagonist on, on day 3, day 4, in the follicular phase only. They started the antagonist rather than waiting for. So they have compared the two group where they have used the flexible protocol and the early administration of GnRH antagonist in the cycle. So the now coming back to the present role of ovarian drilling. We previously, it became the standard of care. However, the downfall came with understanding of the impact of ovarian drilling, because we landed into burnt out ovaries where there were the actually burnt out PCOS, it was called, and this led to the restriction of the use of the current 40 units. What was the current? They defined the cutting current and then the number of holes that were drilled. But still, if we had gonadotropins, we were responding and we didn't want to impact the ovarian reserve. This we are not doing at all until and unless a patient is not able to, even if I do a laparoscopy, I would not do an ovarian drilling. But if the patient is totally unaffording, then probably ovarian drilling. Previously, there was an era, my teacher used to tell me that she had done wedge resection also, and the patient who was totally resistant had responded. So with the present guideline, the impact has completely disappeared. With 4 holes, nothing is going to happen to this big PCO ovary. Now, what is the weight loss going to? This is a patient. This patient was a very, long patient. For many years she was coming and we were not able to handle her LH levels. So came the Corona, and I saw her Facebook picture, and she was so thinned out. She had the balding, and she tells me on the phone that my UPT has become positive. So the impact of excessive weight loss is just unmatched. And bariatric surgery has definite role. We are sending some patients who have morbid obesity for bariatric surgery, and then there is a reversal of metabolic profile and the ovulation starts occurring. So this is our this is our paper of comparison in a 2 groups, clomiphene resistant patients and clomiphene sensitive. And we found that the hyperandrogenemia and the metabolic syndrome was very high. So this was a publication, and we have had our publications included in the Cochrane. So for which, I'm proud of my students who did this work. So these are all our publications. We have the maximum number of PCO publications in the country. And this all is the work of my students who are there. And this is last is the use of fenugreek seeds. When you are trying to tell the patient all the things, fenugreek seed is a very simple option. You can say you use the methi dana, and that, because anything which works in the diabetic patient is going to benefit a PCO patient. So fenugreek seeds we gave the patient for 3 months, and we found metabolic improvement. So to conclude, there is a need to develop sensitization, awareness, and more research and understanding in the syndrome, and to have better outcomes for the future generation, to keep them more keep these women more beautiful, fertile, and disease free, and decrease the burden of this syndrome. So September is definitely a PCOS awareness month. So with this, I conclude my talk. Pooja, we can't hear you.
Okay. Thank you so much, ma'am, for the discussion. It was an excellent talk covering a wide array of things. And I think I need another class from you for learning all the things.
No, you are far ahead from us.
No, ma'am.
Yeah.
I would like to invite the chairpersons, Dr. Savita Singhal, ma'am, Dr. Anju Ahuja, ma'am, Dr. Neelam, Kant, Dr. Aradhana for their expert comments.
I say, Dr. Shalini, it was very wonderful talk, and it was very detailed, elaborately. You have talked about the metabolic syndrome and all the LH high, LH and all, how to manage this. This also you have given a very good stress on the metabolic syndrome and insulin resistance. What I heard you told about the bariatric surgery and all, about to reduce, definitely the reduction of weight, it helps a lot. But there are some liraglutide and SGLT2 medicines have also come up to reduce the weight, and that has really worked. Before the surgery, that can be very well tried. And I've seen patients getting very good results in high obesity where BMI is too high. That
Yes,
is
yes.
wonderful. And it is really wonderful to listen to you, and you are doing a great job. And
Thank
Pooja,
you.
as it is, she is nearer to us and she does wonderful job. Thank you so much. It was nice to hear you. Thank you so
Thank
much.
you, madam. Okay. Okay.
Dr. Anju, you're not audible, ma'am. Dr. Anju, ma'am.
Yeah.
All mute, no? They mute it and forget to
Yes.
stop us like that.
Good evening, everyone. Thank you so much, Dr. Pooja, Dr. Jyoti, Dr. Rakhee, and all the other organizers for inviting me to chair this session. And it was such a wonderful talk by Dr. Shalini. You have very rightly said that we first must reduce the insulin resistance. Only then we can treat the patients of this resistant PCOS patients. And I think a lifestyle change, if the patient does, and especially as you said, that if there is weight loss, even up to 5%, and even I have seen in so many patients that just by reducing their weight, so many patients, they start responding to the drugs of which they were still resistant. So I think change in lifestyle, reduction of weight, and of course, certain how we reduce the insulin resistance. That is all which is required to make a patient respond to the induction-inducing drugs, ovulation-inducing drugs, and that is how we treat the resistant PCOS. Very nice talk by you, Dr. Shalini. Thank you so much, and I think we all have really gained a lot from your talk. Thank you so much.
Thank you for these kind words. And I would really ask and request everybody not to use donor oocyte in PCO who is full of oocytes.
Yes.
So, if you are not able to make her ovulate, give us a chance or send her to another expert, treat her metabolic syndrome and try, because this patient does not deserve a donor oocyte.
Thank you so much.
Okay, ma'am.
Savita ma'am is here. Dr. Savita Singhal ma'am. Dr. Aradhana Kalra ma'am. I think ma'am is not here.
They will not be.
So we'll move towards our next session. I would invite Dr. Rakhee to take over. Dr. Rakhee is here.
Yes. I'm here. So now we go forward with a very nice panel, which will be moderated by Dr. Pooja D, and she runs the Sonakshi Ayurveda Center. Dr. Pooja D Dhyana, and Dr. Pooja, she is the clinical director Sonakshi Ayurveda Center, Rohtak, Jain, Diwani, and like Dr. Shalini has said, she has grown up so nicely in the past years. I had also worked with Dr. Shalini, so past consultant at Nova IVF ISAR, Dr. Pooja. She had done fellowship in infertility and ART Nova Ahmedabad, and she has advanced training in embryology in Bangalore in 2012. And she has undertaken advanced ultrasonography course in obstetrics at Apollo Center for fetal medicine. So many qualifications, Dr. Pooja. We are really very impressive. And she is dedicatedly working. And our next expert moderator is Dr. Meenakshi Mehta. She is a consultant in MS Obs and Gynae at prestigious SMA Jaipur in June 2012. And at present, she has a post-MS last 13 years of experience in this field. She is a past secretary of ISAR Foxy, and she has won prizes in poster presentations at International Urogynec Conference held in Ahmedabad. So welcome to both our dynamic moderators, and let's see what they have to present to the great panel. The chairpersons of our so the panelists, may I ask our moderators to invite the panelists, or should I? Dr. Pooja?
And experts, two experts.
Two experts
so
are
we
there,
have
ma'am.
two.
You can invite, ma'am. You can invite.
Doctor. Yes. So I have a great honor to invite Madam Dr. Nirmala Dhuan. who is my teacher also. She is a senior professor, unit head, Obs and Gynae PGS Rohtak. She's expert for this panel and she has 28 years of Obs and Gynae experience. And she has so many research projects she has supervised, and she has 90, almost 100 international and national publications. So welcome you, ma'am. And our next expert is, please share the Dr. Manju Khurana. And Dr. Manju Khurana is the Director and Chief Infertility Consultant, Gobind Fertility Center, ISAR Haryana, and she's a past chairperson of Haryana chapter of ISAR. And she's very simple, dynamic, full of knowledge, ma'am. And she has so many affiliations. She has running IVF centers in 2003, and she has been invited faculty for many talks all over the India in so many conferences. And her area of special interest are, she has done tremendous work in the field of adolescent health and menstrual hygiene. She has been a part of various activities for education and welfare of girls. Welcome you, ma'am, as an expert for our panel. So over to our dynamic moderators, Dr. Pooja and Dr. Meenakshi.
Thank you, ma'am. Thank you so much. Dr. Meenakshi is here now?
Yeah, thank you. Thank you, ma'am.
So
for the panelists, I would like to invite Dr. Gurneesh Singh. He is a senior consultant at ISAR, Ilora EV Care. Dr. Manisha Mehta ma'am from Sirsa. Dr. Kanta Zola from Rohtak. Dr. Divya Talwar again from Sirsa. And Dr. Meenu Bakar, she's from ISAR itself. Dr. Rakshita, working in Indira IVF ISAR. And Dr. Yogita Dogra, she is at present in Himachal. So, screen sharing is there?
Yes, yes.
Fine. So as we all know, PCOS is a very common condition and it's the most common endocrinologic disorder in females. And if we look at the incidence, it is present in almost 15 to 20% of women of reproductive age. Roughly 1 in 10 females would be suffering from PCOS. And the patients who present to us or the females who present to us, they will have a wide array of presentations in the form of, there could be oligoanovulation, there could be insulin resistance, hirsutism, obesity, PCO pattern of ovaries, and androgen excess. So yes, whenever we look at PCO, it is actually such a heterogeneous condition that sometimes you get confused कि ये patient fall कर रहा है category में नहीं कर रहा है क्या treatment देना. There are many confusions. We will try to sort out certain things which we actually see in our clinical scenario. So coming to case 1, she is Mrs. X, 22 years old female with a BMI of 26, married just for 1 year. Her periods are regular, lasting for 3 to 4 days, occurring every 30-32 days. And she reported with a USG finding of PCO morphology on USG. She was evaluated outside, her testosterone and free testosterone measurements were done. And they were towards higher side of normal. The semen examination had already been done for the husband. It came out to be normal. So my first question is for Dr. Gurneesh. Dr. Gurneesh is here.
Yes.
Sir, is she a PCO? Do you label this patient a PCO?
What information has been come? She is not having any irregular cycles. She is not having any clinical and hyperandrogenism or any hirsutism. So she is not PCO. And why she went to examine perhaps for slight obesity because BMI is more than 25. For that, you cannot diagnose her as PCO. And I think lifestyle modification reassurance was enough. So definitely she is not PCO.
Yes,
as
sir.
far as history is concerned.
Yes, sir, definitely yes. Why I put this question? Because young females would be coming into the OPD with the ultrasound report showing कि ultrasound वाले ने बता दिया मेरे को कि PCO है मेरे को, so they are all worried. So in these situations, we need to reassure them. We need to tell them कि PCOS ऐसे ही नहीं सबको हो जाता है. It could only be an incidental finding also. So how do we diagnose PCO?
For diagnosis of PCO, as far as recent guidelines are concerned, there should be a menstrual irregularity or ovulatory dysfunction along with hyperandrogenism. Either clinically it will be visible or biochemically. With it, presence of PCO in ultrasound may or may not be there, provided that other causes like thyroid and hyperprolactinemia and hypothalamic causes are not there. This is the definition that hyperandrogenism and menstrual irregularity must be there.
Right. So there are different criteria. The most common criteria that we use is the Rotterdam criteria, which was laid down by ISAR and Asha in 2004, which includes oligoanovulation, hyperandrogenism, and ultrasound suggestive of PCO. And this is a recent diagnostic algorithm which has been put up in the 2023 guidelines. In case a patient comes to you with irregular cycles plus clinical hyperandrogenism, you need to exclude other causes. In case both the features are there, you straightway label this patient as PCOS. In case there are no clinical hyperandrogenism, then you need to test for biochemical hyperandrogenism. In case it is there, then again you land up in diagnosis. If there are only irregular cycles or hyperandrogenism, then in that case, you can go for a scan for this patient in case she is above 8 years of post-menarche. And in case the scan is suggestive of PCO morphology, and one of the signs is there with irregular periods or hyperandrogenism, your patient is a PCO in that case. How do you define PCO morphology, Dr. Manisha ma'am? Are there any changes in the recent guidelines? Dr. Manisha is here. Dr. Manisha? I think Dr. Rakshita can take up the question.
Hello, ma'am. Good evening. I'm sitting here with Pooja, ma'am. So yes, there has been some changes in the guidelines of PCO morphology. So when we look at the ultrasound, we see the follicular number in the whole ovary as well as in a section. In whole ovary, it should at least be 20 follicles visible, which we are talking about the smaller follicles. And if we look at a section, then more than 10 should be at least there in one section in one ovary. When these findings are there, then we can suggest that this is a PCOM, that is PCO morphology. Ovarian volume, if it is more than 10 ml, then also it is labeled as PCO.
So yes, ovarian volume is much more important when you are doing a trans-abdominal scan, although we all go for a transvaginal scan to label our patients as PCOS. But ovarian volume holds importance in case of trans-abdominal scans. And this is a recent criteria where we have been using the good transducers with high resolution, where they have shifted the criteria from 12 to 20. What is the clinical significance of PCO morphology? A patient lands to you, just like pehle humne baat ki, the patient came with an ultrasound report of PCO morphology. Any conditions where you can actually see PCO morphology physiologically or in routine practice? Dr. Kanta, please.
Yeah, good evening, everyone. A PCO morphology, but who's ovulating, who doesn't have any clinical or bio, we can to be, it's like not very morphology without any ovulatory dysfunction. We can maybe just see that, think that it is a kind of on a higher side of a risk for PCOS, and we just need to advise her to maintain a normal maintains a normal PCOS.
Dr. Kanta, your voice is breaking in between.
Actually, there's a bit of network issue. PCO morphology, 50% of patients without having PCOS, and PCOS patients who have PCOS, like 20% don't have PCO morphology. So in case only if the morphology is there and she's ovulating and there's no clinical signs or biochemical excess, androgen excess, we can't. Patients only just asking them to maintain a normal health lifestyle, a normal BMI, and just to be on an alert. That's it. Nothing to do much about it, and not to scare them. That is my take on it.
Yes, the crux is don't make your patient scared. PCO morphology isolated without PCOS could be seen in various conditions. For example, in hypothalamic amenorrhea, you can have a PCO morphology of the ovaries when the patient is having raised prolactin, or very commonly seen in adolescent group, PCO morphology, you can see in adolescent group. Now, the clinical relevance, the finding of PCOM in ovulatory women does not showing any clinical or biochemical androgen excess may be inconsequential. But yes, there are certain studies which suggest that it could be a milder spectrum of PCOS. So these patients need to be monitored. Just like Dr. Kanta said, weight monitoring, BMI monitoring, or making the patient aware of this. Otherwise, don't scare the patient. So do you think that in case a patient lands to you with a PCOS morphology or PCOM, sorry, not PCOS. So does it lead to development of PCOS in future? Dr. Yogita is here.
Yeah, hi, Dr. Pooja. This is Dr.
Hi,
Yogita.
Dr. Yogita.
I think alone PCOM in regularly menstruating women with no evidence of any hyperandrogenism, I think is not a major risk factor for development of PCOS in future. Because PCOM, we can see in almost 25% of the women in absence of PCOS. And just now you said that adolescent group also have PCOM as normal ovarian morphology. And it has been seen that because of ovarian aging, also maximum patients in whom we see baseline PCOM, they actually fail to meet the criteria over time. That may be because of the ovarian aging. That is one of the factors. And so I think PCM alone without any other steroidogenic dysfunction is not a predictor of PCOS in future. However, we may keep monitoring these patients if they have slightest of the ovarian dysfunction. For example, mild dysregulation or AMH elevation, like you are showing in this slide. So normal variant PCOM is also there, in which in few 10% of the patients, just the AMH is elevated, no other factor is there, no other ovarian steroidogenesis dysfunction is there. So these patients, definitely we have to keep them under evaluation part. But as such, in normal ovulating, normal menstruating, just incidental finding of PCOM is not a major risk factor for future PCOS.
Rightly said, Dr. Yogita. So is there any condition where you see a PCOM and you should be afraid of something when you're stimulating your patient? Is there something you should be afraid of when you're stimulating a PCO morphology patient? Dr. Divya, please. Ma'am is here.
Yes, ma'am. Hi. Whenever we are stimulating a patient who has a PCO looking ovary or a PCOM morphology, we should be careful of overly stimulating the patient. We should be careful of hyperstimulating the patient, because there is always a risk of multiple follicles forming and a risk of associated OHSS or multiple pregnancies if we go ahead in an uncontrolled way. So it should always be a controlled ovarian hyperstimulation in cases of PCO.
Rightly said, Dr. Divya. This is the only negative thing with PCOM morphology, that when you're stimulating, you have to be just like you are stimulating a PCO patient, because in that case, your patient might land up in OHSS. Sometimes you see the patient is lean thin with some kind of PCO morphology, and you give CC50 and you land up in 5 or 6 follicles sometimes. And then you have to decrease the dose next time. Now, Dr. Meenakshi, please.
Thank you, Dr. Pooja. Now, the second case is Mrs. ABC. She is married for 1.5 years and she has an ovulatory cycle of 42 days lasting for 3 days. Her husband's semen analysis is normal. BMI is 30. There are clinical signs of hirsutism and acanthosis nigrans is present. Next slide, Dr. Pooja. Now, my question is for Dr. Meenu. How would you like to start the treatment for this patient? Dr. Meenu, are you there?
Yeah. Good evening, everyone. Because the patient is a typical case of polycystic ovarian syndrome, fitting the anovulation criteria and hyperandrogenism features like hirsutic and obese, this patient has to be started with the non-pharmacological methods with lifestyle modification as first choice of treatment. She should be encouraged to lose weight, and loss of 5 to 10% of the present weight can help her achieve her normal, minimize the hyperandrogenic features, and normalizing the metabolic endocrine environment of the body. and regular exercises, regular sleep patterns will help definitely correct the endocrine irregularities. And in pharmacological treatments, the first line of management will be oral ovulogens. And with the letrozole as the first choice oral ovulogen along with clomiphene, the patient can be given metformin in oral medications.
Yeah, thank you, Dr. Meenu. Yeah, the first line of treatment must be the lifestyle modification with more stress on weight loss. And we should give the target to the patient to at least she should lose 5 to 10% body weight, which will help in reducing the insulin resistance. The signs which are seen over there, the acanthosis nigrans is there, which is a sign of resistance. Metformin can be advised, which is in the pre-treatment. The foremost important is the lifestyle modification. Next slide. Now over to Dr. Rakshita. Any role of pre-treatment in this, in such profile of patient?
Yes, ma'am. So as Shalini ma'am rightly said that there is a significant role in reducing the insulin resistance in these patients. As she said that many of the PCOS patients just land up in oocyte donation when the response is not seen. So to improve that, to manage the weight, hormonal and metabolic outcomes, metformin has been seen to be effective. The recommendations are strong with the weak evidence. Still evidence is weighted, but in clinical practice as well, we see that metformin helps a lot and should be started at least 4 to 6 weeks before we are planning any form of stimulation in these patients. Also, metformin has been seen to give better response, a better oocyte quality, and it can be started before as well as continued during the stimulation if we are doing controlled ovarian stimulation. And the studies also say that when metformin is used along with clomiphene citrate, then there is a clinically significant increase in ovulation rate when it is only compared to CC. Also, metformin can be continued in pregnancy as well, but it is only continued in pregnancy if there are indications. So similarly, we have other pre-treatment also, like Shalini ma'am said that there is myo-inositol. It is like a supplement only, but it plays a pivotal role in down-regulating the release of free fatty acids. And inositol, when compared with metformin, has much lesser gastrointestinal side effects. So we can try metformin, can try by starting with a low dose and increase it up to 2500 mg per day. And inositol we can try in these cases because it will help in normalizing the cell glucose metabolism and therefore decreasing the insulin resistance in these patients. And this can also be started before giving the patients any fertility treatment.
Yeah, thank you, Rakshita. Yeah, in such profile patient, it is important to reduce the insulin resistance, which can be done either by metformin and myo-inositol. Obese patients should be given metformin. And myo-inositol, it also reduces the androgen excess. Now, the next question for Dr. Yogita. What are the protocols for ovulation induction you will advise to this patient?
Okay, so the ovulation induction protocol that we usually advise in PCOS patients is the first and foremost, the first line of drug is the letrozole. So letrozole, we start from 2.5 milligrams from day 3 to day 7. And as such, we do the follicle monitoring. Everybody, we are doing it in the clinical practice, in our day-to-day practice. So everybody knows about the how we are going to do the follicle monitoring in these patients. So along with lifestyle modification, obviously letrozole we use. The protocol is 2.5 milligrams for 5 days, starting from day 3 to day 7. And accordingly, when the follicle has attained the 18 to 20 millimeter size, then we can do the HCG trigger path.
Yes. Letrozole is the first line of oral ovulation, which is given to such patient. And for letrozole also, 2 protocols more are available. One is the extended letrozole protocol. If the response is not there for 5 days, it can be extended to 10 days. And step-up protocol is also there when slowly the letrozole dose is increased till 7.5 mg.
Yeah, that is step protocol.
Yeah. Now the next
question here.
Next question. Any comment on gonadotropin, Dr. Yogita? When you
Gonadotropins usually, gonadotropins are usually the second line agent who have we usually prescribe in patients who have failed with the first line therapy. And so gonadotropin also we have different protocols available. For example, the chronic low dose protocol, the conventional step up protocol, or the step down protocol. So it depends which protocol you want to use depending upon the patient profile. Usually the chronic low dose protocol is preferable because there is less chances of the multiple pregnancy and OHSS risk. So, but there is a disadvantage that longer duration of treatment is there. So it depends upon the clinician expertise and the patient profile also, how many times she can come for the follicle monitoring and the cost factor. Depending upon, we can choose whatever protocol you want to choose.
Okay. Thank you, Dr. Yogita. Now over to Dr. Pooja for the next profile.
So another patient, Mrs. Y, comes to you at the age of 30 years. She has a BMI of 30 and she has been married for 5 years. For past many years, she only had withdrawal bleeding. She had hirsutism. Semen analysis done for the male revealed a normal semen analysis. And in the past 5 years, she has taken many cycles of ovulation induction with oral agents, but no response was there. So what is the diagnosis in this patient, sir? Dr. Gunish, sir?
Hello. Yes. This is a case of we having already disorder, like she is having only withdrawal bleeding. She is definitely case of PCO because hirsutism is present, ovulatory dysfunction is present. Along with this, she's grossly obese, like BMI is 30. So first of all, as we were listening to Dr. Shalini, that overweight itself may make it resistant for ovulation. First, lifestyle modification should be advised in this case. So she's a case of this PCO, in which first we should go for lifestyle modification. I advise her to lose 5 to 10% of the weight. And then again, we can try CC or letrozole along with metformin. If they don't work, then we have to go for gonadotropin. If because of any reason laparoscopy is indicated, like for endometriosis or for anything else, then along with that, laparoscopic ovarian drilling may be done. And with that, fully within 3 to 6 cycles, she should ovulate and achieve pregnancy. Otherwise, then last third line treatment will be IVF.
Yes, rightly said, sir. As it had been in the past discussion, there was a lot of discussion on resistant PCOS. First of all, we have to treat insulin resistance and we have to advise the patient for a healthy weight. Other line of management, pharmacologically, you can give insulin sensitizers, gonadotropins is a second line of agent. Laparoscopic ovarian drilling, yes, in case you have a patient who is planned for laparoscopy and the patient is PCO, you can go for laparoscopy for this patient. So the second line agents we talked about is gonadotropins. So before you proceed for gonadotropins, how do you decide how much dose I have to give to this patient? Dr. Manisha, ma'am is here or I think she had left.
No, Dr. Pooja,
Ma'am
I'm
is
here.
here.
Yes, I had some problem.
Right, ma'am.
Point, yeah. Dr. Pooja, about this patient, I want to point out 2-3 things. Number one is that I would love to do a laparoscopic ovarian drilling. Ma'am, Dr. Shalini said that LOD is out of this thing, but I usually describe PCOS ovaries as sleeping beauty. So sometimes, just digging 2-3 holes in it awakens them up. In fact, we people as an IVF specialist have also seen so many times that after pickup, even if we've frozen all the embryos. So many times the patient gets pregnant before we've planned a transfer. So drilling. In fact, in X-ray, I heard of a talk that people drill even without a current. So such people who've just having withdrawal bleeding, there is a role of laparoscopic ovarian drilling. That's one point which I want to say. Yes, now you were asking about how will I decide the dose. One more thing in such patients I would like to do, if I have to stimulate with gonadotrophins, I usually like to down regulate them in 1 or 2 cycles. But you can give simple OC pills, the kyproteron acetate, whatever, so that by down regulation, what I mean is I'm trying to bring down her LH. And then I like to go about stimulating with gonadotrophin. I usually like to start with 37.5. After 4 days or 5 days, I'm going to see the response. If suppose I'm happy, it's fine. We give a continuous low dose rather than, going up with the dose if I'm talking about a normal ovulation induction and not IVF. So over to you.
Right, ma'am. For gonadotropin doses, we need to keep certain things in mind. One is the BMI of the patient, what treatment protocol she had been on initially. And yes, we have to be aware that these patients will have very unpredictable response. The response may be very slow, or sometimes you have a patient who lands up in hyper response. So rightly said, start with a very low dose protocol for this patient. Other factors which will affect the response for this patient will be the age, BMI, ethnicity, smoking, other infertility factors, genetic receptor polymorphism, or past performances. Then important markers, they are AMH and AFC. What do you think, ma'am, is more important, AMH or AFC? What do you take into consideration when you stimulate your patient? You go for AMH for all the patients, or you depend upon your scan findings?
So look, if I'm talking about a normal induction and I'm not planning an IVF, I don't do AMH in all the cases. I am more this thing on my clinical findings. Yeah. So I see if it is such an ovary, so I know that, I have to go pretty long on a small dose. I want to add something. I always add letrozole to such patients because they will help in avoiding the premature LH surge. And usually my letrozole dose with gonadotrophin would continue till the day I have given a trigger.
So you continue letrozole till the day of trigger?
I mean, it could be at least, yeah. Even in my IVF protocol, I always plan letrozole. It avoids the premature progesterone and the LH surge. So letrozole, yes, because of its anti-estrogenic effect. So I like to add letrozole to such a patient with gonadotrophin as well.
Fine, ma'am. I think I am learning something new. So I may keep this protocol in mind. So you add letrozole right from the beginning and continue it till the trigger day.
Yes, I do it.
Right. So precautions, I think Dr. Kanta, this is...
it's already mentioned.
It's already covered.
Yeah, it's already covered.
Next. Okay. Is there any difference between the type of gonadotropin that you use for a PCO patient, whether you use FSH, you use HMG, you use urinary product, or a recombinant product? Dr. Divya?
Yeah. So actually, initially, we were thinking there were so many studies which used to say that recombinant FSH is much better in PCOS, but now what we know is that the live birth rate with all the 3 types of injections, whether it is recombinant, whether it is urinary, or if you are giving HMG, it is almost the same. So it depends on your patient's pocket, how much money he wants to spend, and accordingly you can decide which type of injection you want to use for your patient.
Yes, you can use any type of injection. It all depends upon availability and cost effectiveness for that patient. Now, ovarian drilling. Dr. Manisha has covered a part about ovarian drilling. Dr. Meenu, can you elaborate? Are you drilling the patients in PCO patients? Are you doing ovarian drilling, or
Yes, we are doing ovarian drilling for PCO patients, especially the patients which this type of patient who are having who underwent multiple ovulation induction agent cycles, and they are resistant cases, married life 5 years, and patient is from far off places not able to come for regular monitorings, and for ultrasound monitoring they cannot come. Laparoscopic ovarian drilling is the if we do not opt for gonadotropin, then this is the second line management for such patients. And they have laparoscopic ovarian drilling has many advantages also, like it decreases the risk of multiple pregnancies, and you don't have to monitor patients on a regular basis. You can just do the drilling and leave the patients also for some time. And many patients conceive in our experience
with drilling. So how do you choose कि किस patient को drill करना है, किसको नहीं करना है? Dr. Rakshita or Dr. Meenu, anybody can take up.
So, as Dr. Meenu has already stated, where all we do the laparoscopic ovarian drilling, we have to keep in mind that the duration of infertility should not be very long. At least it should not be more than 3 years.
Patients have conceived. Having
really choose. Yeah.
Right.
Also, we will keep in mind that the patient has normal BMI, since there are many guidelines who state that in cases who have higher BMI, the response after LOD is very poor. The patients who have LH more than 12 international per liter, or who need any laparoscopy because of any other indication, they can also go ahead with laparoscopic ovarian drilling. But there are some cases in which we will get a very poor response after laparoscopic ovarian drilling, and those which we have to keep in mind are very obese patients who have long duration of infertility, who have low basal LH levels, and who have marked biochemical hyperandrogenism with high basal AMH. All these cases might lead to poor reproductive outcome even after LOD, and thus we have to counsel the patients accordingly and select the patients accordingly.
Rightly said. Drilling initially definitely had a role, but over the time, I think I've seen it fading away. And now again, with the ASHRAE guidelines, drilling has come into light because it is as such considered as a second line agent for certain group of patients where you cannot actually give gonadotropins, maybe because of affordability issues or certain other issues where a patient cannot get regular monitoring for a cycle. So in those patients, whenever you're drilling your patient, you need to choose your patient very judiciously. And counseling is very important because drilling, in your practice, Dr. Meenu, how many patients do you think respond to drilling?
When we counsel the patients, we say them 50-60% chances are there that they can conceive within 7 to 8 months post drilling.
Right.
And practically, we have seen conception rates near about 30-40% post drill.
Right. So that is what I mean to say when I say about the counseling prior to drilling. Your patient may respond or may not respond, but because till now we don't have that data कि कितने drills करने से कोई भी ovary respond करेगी. There are predictors, इतना volume है, इतने drills करो, but still we cannot apply it practically in our routine practice.
Counseling is most important for these patients.
Right. Very right. So a resistant patient, insulin sensitizers, metformin, inositols. I think this is almost covered. Myoinositol, how many of us are giving in our routine practice? To all the panelists who all, how many of us are giving myo in our routine practice?
We are giving.
We are giving, right.
Giving.
So I think everybody is giving myoinositol.
And how many of us are giving the combination, the metformin and the myoinositol? Both the drugs.
Yes.
Yeah.
How many? I think Dr. Yogita, you have been using, I think.
Yeah, I am using.
Yes. So these two drugs are actually known to have insulin sensitization, and with mayo as a newer drug after metformin, it has been seen that it normalizes ovarian function. There are studies where the levels of testosterone have been lower, insulin resistance has been lower, there has been better oocyte quality, better embryo quality. Practically, if you ask about me, I have not been using much of myo-inositol. I'm still sticking to metformin in my practice. I don't know why. And Dr. Yogita, you can actually elaborate in case you have been using the combination, you have been using mayo too much. You can actually elaborate on the role, I think.
No, actually, see, myo-inositol and D-inositol, when we give it this in 40:1, the recommended ratio. So this has shown to have beneficial effect in the form of normalizing the ovarian function. It improves the, actually, when we give it at least 3 months prior to any treatment or along with any treatment, whatever I am giving to PCOS patient for, let's say, for example, plain ovulation induction or IUI cycles, I always start my patient so that even if the patient lands up in, IVF, at least the patient is on a minimum of 3 months of this insulin sensitizer prior to any IVF treatment. So it actually improves the oocyte and embryo quality, decreases the androgen levels as well. And it many of the patients, it restores the regular menstrual cycles as well. So when we give, this is available in 550 milligram of myo-inositol and 13.8 milligram of the D-inositol combination. So I give in the twice a day dosage, right? So when we give myo-inositol and D-inositol, both these drugs are actually required because when we give in combination, both have different biological processes, both regulate different processes. For example, myo-inositol will mainly improve the ovulatory function and D-inositol will reduce the peripheral hyperinsulinemia, right? And I prefer to give metformin also in patients in whom both the ovaries are, severely PCOS. There are like 20 to 25 follicles in each of the ovaries, resistant, not I'm not getting any response with the normal ovulation induction. So I always add metformin, and especially in obese patient, in hirsute patient, I add metformin also into these patients because in the recent 2023 guidelines, that international evidence-based PCOS guidelines, they have also said that metformin is usually considered over myo-inositol in patients with hirsutism and central adiposity. However, metformin has more of the GI side effects, and somehow we prefer myo-inositol because of the lesser side effects. And also, when we give the combination myo-inositol as plus metformin, what it does is that the dose of metformin we can reduce. The dosage is reduced so that the GI side effect is also reduced. So I am giving, I'm not giving the combination drug to all patients. In few patients, I am giving just metformin. In few patients, I am giving the combination.
Right. So presently in the recent guideline, although they have said that myo-inositol has a lot many effects, but still they say that in any form myo-inositol or in combination with other therapies, it should be considered experimental. This is a recent 2023 guideline, but yes, it has been shown to have an improvement in the biochemical profile, in improvement in the insulin resistance, testosterone levels in PCO patients when myo is used.
Yeah.
So I think it is on the clinician's perspective, their experience they have been using. Now moving to case 4, Dr. Meenakshi.
The next case is 34-year-old Mrs. ABC. She is an IT professional in multinational, married for 8 years, and she consulted us for infertility. Her menstrual history, she has 3-day cycle, 1.5 to 2 months, irregular, mild dysmenorrhea. She has taken 2 cycles of IUI. On examination, hirsutism is present. Her BMI is 31 kg per meter square. On scan, polycystic morphology is there. HbA1c is also raised, 6.5%. AMH is on a higher side, 10 nanogram per ml. Husband profile, semen analysis is normal. Now the next slide. Next slide.
Next slide is here.
Next slide. Again, the next.
Is it visible? I'm on the next slide.
No, turn next slide.
No.
Yes. What will be the next line of management? Should we go with for repeat IUI or should we advise IVF? Dr. Guneesh, sir? Sir, are you there?
Yes. Yes. Hello. So this is a case of PCO with obesity and gross obesity because it is BMI is more. So in this case, I think lifestyle modification and advice for weight reduction and exercise should be given, because that may be the cause where she is not getting benefit with the IUI. After that once we have done that, then I will like to, in her age group, 34 years age, I would like to definitely try for 2 to 3 cycles of IUI. And as she's nearing 35 and she might not like to take more than 3 cycles, I will not like to give. Already she has taken 2, so I will give 2 to 3 more. If she does not respond within 2 to 3, despite of weight loss and despite of achieving ovulation, then I may advise her IVF. And as far as protocol is concerned, I will definitely try to use letrozole along with metformin, and if required, if that ovulation is not achieved, if required, then neurotrophins.
Okay, sir. True, sir. This patient is an obese PCO patient and 2 cycles of IUI she has taken. We should take the history whether the IUI cycles were with the oral ovulation or gonadotrophins. After lifestyle modification, weight loss, we can try 1 or 2 cycles of IUI. If still not achieved, then we can proceed for IVF. Next, Dr. Manisha, ma'am.
Okay, I liked one point Dr. Shalini said, that you were talking that she has got high androgen levels. So why not give her spironolactone for 2-3 cycles, bring down her androgen, and then do a nice ovulation induction? That is one point which was coming to my mind. And next thing which was there was that she's an IT person. So one thing which I would like to add to her is the melatonin or something which gives her a better quality sleep. One thing. Second, I would advise her not to use mobile phone after 8 o'clock, because if you see this generation, they are very highly on, the social media and this and that. And if the quality of sleep is not good, it is just not, when we are talking about a patient, it is just not 2 + 2 4 that we have done 2 IUI, it's not done. So a very high role of the lifestyle modifications, because she was an IT person. And that's it.
Yeah, true, ma'am. In the lifestyle modification, basically for these professionals, the stress level has to be cut down and the sleep cycle should be better. And it should be counseled to the patient that this is important, apart from the weight loss.
It is very important. And next thing, as Dr. Guneesh was saying, since she's already 35 years old, we have to see what is her AMH levels.
AMH is 10, ma'am.
Okay. And the FSH, if she's not going to be menopausal soon, we can just take 2-3 cycles after her lifestyle modifications as well. But suppose if we are kind of thinking. And one more thing which ma'am said, Dr. Shalini, about the reactive oxidative species. We have not talked about the antioxidants which we should also add to the protocols. Right?
Yes, ma'am. The question is for you. What protocol will you like to follow in this profile of patient?
You're asking me about the protocol for ovulation induction?
Yeah, ma'am. Both ovulation induction and IVF. If the patient lands for IUI, what protocol will you follow? And in case the patient wants to go for IVF, what protocol would you like to follow? Which is the safest one?
Naturally, her AMH is very high. I will not follow the long protocol. As I said, if I'm talking about IUI, since she's come to me, she's taken already 2 IUI cycles. I would like to downregulate her, bring down her AMH, bring down her androgen levels by giving spironolactone, and kyproteron acetate and then do ovulation induction. I would see if she's taken 2 cycles of letrozole. I would like to try with clomiphene citrate because I usually feel that every patient's body is different. So trying a different thing could be another option. And that's about the IUI. But if I'm talking about IVF, we definitely are not talking about the long protocol because her MH is so high, I cannot afford to give her HCG.
So the entire protocol will be there?
Yes.
And agonist trigger.
But the ANTAC protocol or in these days we are doing one protocol where we, along with stimulation, we are giving medroxyprogesterone acetate till the time of HCG. It's very simple and I'm really happy with it. It really brings down the cost.
Yeah, it's very cost effective.
It's very cost effective.
Yes, true, ma'am. And even the embryo quality is fine over there.
It's nice. It's very nice. Surprisingly, first few times I was quite apprehensive, but in fact, now my 80% protocols are with medroxyprogesterone acetate. So it's become,
Okay, next slide. Now over to Dr. Kanta. What are the strategies we should follow to prevent OHSS in this profile of patient?
Yeah. Basically, it's a good monitoring of the cycle when we are giving gonadotrophins or anyways doing ovulation induction, especially for this patient, and not going for any, say, aggressive stimulation protocols, titrating our doses, going for very controlled ovulation stimulation. And when we are planning, just when we see there are more than 2 dominant follicles, this cycle or convert that cycle to an IVF cycle. And if we are doing it an IVF cycle with such a high AMH and all, better to use an ANTAC protocol. And instead of giving only HCG, go for an agonist trigger. And still, if we feel then a costing is also very useful in this. Prolong the duration, decrease our also give the low dose gonadotrophins and give HCG trigger at a time when your estradiol levels are good enough. And if it's an IVF cycle, I would abort this, freeze all the embryos and transfer in the next cycle. That will be the thing.
Okay. So in ovulation induction, basically we should be cautious about the dose which we are giving and the gonadotrophin, especially which are being given in certain cases. And most important is the ultrasound should be done by the gynecologist who is giving the hormones, because most of the time the radiologist miss these small follicles which are progressing and which may lead to high E2 levels. If you are not doing the scan, you should get the E2 levels done. And if it is more than 1200, you should either abort the cycle or convert the patient to IVF if the facilities is over there, or send the patient to the specialist. And for IVF, we all prefer the ANTAC protocol, and the agonist trigger is there. And especially elective single embryo transfer is done if you are going with the fresh cycle. Most of the time, the freeze cycle is being done for such profile of patient. Right. Now next.
I have a question, Dr. Manisha, or anybody can tell me, because I'm not into that much. How many people have been down-regulating the patients before they plan for IVF for PCO patients? I'm talking about IVF, not for IUI or OI. How many of us are down-regulating them with the use of OCPs?
If you're asking me, Dr. Pooja.
Hanji ma'am, Hanji, please.
मतलब अगर हम IVF के लिए ले रहे हैं तो I don't know down regulation is important or not, but if you are doing in a batch or 2-3 together, तो आपको इकट्ठा करने के लिए you have to give
you have to give pills in that case.
Which nowadays I use estradiol validate.
Okay.
Because it improves the yield and the quality. As I told that instead of even the ANTAC protocol, I've switched to the medroxyprogesterone acetate in 80% of my cases. So just to time them, what I do is I use E2, which I can give in the secretory phase, or I can give from the day 2. And I stop, I give a 48 hours gap, and I start stimulation after 48 hours, irrespective of periods. Especially in such cases, it has to be 100% freeze. Because with the medroxyprogesterone acetate protocol, we should not be transferring. Yeah.
Right. Fine. Any other person having experience with the down-regulated protocols?
I am giving OC pills to down-regulate or and to down-regulate, then get the periods. For donor cycle, I am using PCOS, which Madam she was saying, and for the patient cycles, I am using Cetrolix. That is anti.
Okay.
I had just one question for Dr. Manisha. When ma'am said she is using estradiol valerate for patients instead of oral contraceptive pills, I just wanted to ask whether you give ma'am medroxyprogesterone acetate also to such patients in the late luteal phase, or the purely estrogen?
It is fine if you want to give medroxyprogesterone acetate along with it, but why am I giving estradiol valerate? I am giving because I want a better yield, because in poor MH patients or the patients who are poor responders, estradiol valerate is supposed to have a very good effect on the next cycle. So it's not just with only a variety of patients. To time my stimulation, I've started it regularly, but yes, you can also add on medroxyprogesterone acetate in the second part. But since I told you I am giving it 48 hours gap, and then I start medroxyprogesterone acetate, so there's no point because I'm not worried about the periods.
Okay. The day you start stimulating, medroxyprogesterone acetate is started on the same day for PPO
BD, and I my last dose is in the morning of the trigger day. Yes.
Thank you, ma'am.
So that's all I think for today's discussion. The experts are here with us, Dr. Manju Khurana ma'am and Dr. Nirmala Duhan ma'am. Ma'am, please.
Yeah, Pooja. Good evening, everyone. It was a beautifully conducted panel discussion by Pooja and Meenakshi. And you were really thorough in discussing the entire spectrum of the issues pertaining to the infertility in PCO cases, starting off with the polycystic ovarian morphology only, and then going on to the non-responders with oral agents, and later on discussing the LOD versus the gonadotropins as well. Very beautifully conducted. And I think we are much wiser at the end of it all. And I would just say that we are here at Rohtak, we were doing that LOD thing almost a decade ago, and we left beyond that in favor of gonadotropins. But at that time, we used to teach that these are equally kind of the results or responses are almost equal. So LOD is also one of the choices, and we used to do a lot of them in those days. But good that it's given up in favor of gonadotropins, and we are really happy with that part. And as the literature also suggests the same, learned a lot from this myself, from the entire discussion. Thank you for inviting me for as an expert. It was a very nice and significantly useful discussion. Thank you. Thank you very much.
Dr. Manju ma'am is here. Dr. Manju ma'am.
I'm here. Yes.
Anju ma'am, Anji.
Good evening, everybody. And it was a thorough, wonderful session, and everybody must have learned something or the other. In totality, I will like to share that we should see PCOS as a full picture, not as one. So patient's age, her married life, now a profession also, her BMI, and previous history, that is very important. Whether she has taken all this, then move on to IVF, because ultimately she wants pregnancy. So it was a wonderful session, And I think we may not be having any question left after all this discussion. Thank you for inviting me, Pooja. Thank you, Meenakshi.
Thank you, ma'am. Thank you so much. Thank you. Thank you so much, ma'am. Dr. Lakshmi is here.
Yes, I am here, Dr. Pooja. So I think it was a beautifully conducted session, panel, very nice questions, very nice cases. The panelists were very good, and I think they have answered all the questions, and all the doubts were cleared, and we have learned so many things that were new. So I think the whole webinar was a very good, it was a successful webinar, starting with the talk of Dr. Pratik Tambe. I would like to thank sir and the chairpersons, Dr. Shalini ma'am, and the chairpersons for this session, and all our both our moderators and the panelists. So now we would like to conclude the session with this, and we will meet in the next webinar, which will be on 8th of October with a new topic. And thank you, everyone. Thank you, Dr. Deepika.
Thank you, ma'am.
Thank you. Please conclude.
Thank you, Dr. Pooja, making me part of it. Thank you.
Thank you all. Thank you all.
Thank you
for being a part
So
of
before
this.
we close, I'll just take you all through our two of our products for PCOS. One is the myoinositol dechiroinositol 40:1 ratio, Cystelia-M. And the other one is for the acne and hirsutism associated with PCOS, that's Cystelia 35, cyproterone acetate, 2 mg and estradiol, ethinyl estradiol 35 mcg. So looking forward to again another episode of the series. Do join us next month as well.
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone.